Hey, Sarah, sorry I'm a minute or two late there. I'm going to share my screen. What I was just sharing with everybody is I just came from the active shooter training. And so I want everybody to just, again, I'm not trying to scare anybody, but just sort of be thinking about what could your strategies be in various places on this campus, including this classroom. So, yeah. So this is entirely acted, not necessarily well, I'll put that out there, but gives you some good strategies to be thinking about.
Hi, can I get you started with drinks?
Oh, I'm sorry, I gotta take this.
We'll need a minute.
No, I'm here.
Hey, you need to back up. You can't be here anymore. Get out of my face, what, man. You think I'm afraid of you? Get off, man. 911, there's a clip.
Chances of survival. Don't go up here.
Police, where is he?
By the bar, blue jeans, black shirt. Empty hands up, follow their instructions.
I'm in the direct line of fire if I head for either exit, but I have other options to help me survive. Guys, come on, in here. Come on. Go, go, go. Lock and barricade the door.
Both my exits are blocked by the shooter. I gotta stay hidden. I'm no victim. I'm ready for this.
He's applying direct pressure to the wound to stop the bleeding until we can find a tourniquet. In the meantime, turn off your phones and make a plan to defend yourself.
We have to fight to survive. If you control the weapon, you control the shooter. I'll go for the gun. He'll go for his arms. The bartender will go for the head.
Where is he?
We got him right here.
Please, show me your hands!
Over here.
You can survive a mass shooting if you're prepared. Remember, run, hide, or fight. Run. Wherever you go, be aware of alternate exits. Quickly and cautiously evacuate in a direction away from the attacker. Don't hesitate. Seconds matter. Remember windows and emergency exits. Leave belongings behind. Keep your empty hands raised and clearly visible when exiting a building. Follow all instructions from the police. Don't stop until you're sure you've reached a safe location. Hide. If there is no safe escape route, find a good hiding place. Lock and barricade the door. Silence cell phones. Prepare a defense plan. Fight. Fight only as a last resort. Use available objects as improvised weapons. Use teamwork and surprise. A coordinated ambush can incapacitate an attacker. You're fighting for your life. Don't fight fair. Stop the bleed. A victim can die of uncontrolled blood loss in 5 minutes or less. Apply pressure or a tourniquet to control severe bleeding. Go to fbi.gov/survive to learn more.
So again, not trying to traumatize anybody or anything. I just thought that this was really important to think about. It really resonated with me. This is something I have honestly thought about, is like, how could I protect y'all? Right? If there was ever, heaven forbid, an active shooter on our campus. And I sort of asked him, like, a lot of our classrooms only kind of have one exit entry point. He's like, are there windows? Don't forget, he's like, use those. So like, I'll come in at some point and figure out how to take out those screens, right? And we'll be prepared for that. You know, ideally, if we know the person's in that hallway, we can all go out that way. The nice thing about this room is the door does close that way, and we can barricade it. So again, I'm not trying to freak you all out, but just this training really made me think about how you should be prepared in any scenario. I think so, particularly if there are classrooms that you teach in, or you have classes in quite a bit, kind of thinking about those solutions. So again, hopefully we'll never have this happen on Virginia Wesleyan. But unfortunately, it's happened on places with good security like ours. Like, I don't know how many people are from here and remember the mass shooting at the Virginia Beach Building 2 a few years back. You needed a card to enter that building. So it was one of their coworkers, right, who had access. So again, just something to think about wherever you are in terms of keeping yourself safe. And obviously, I think one of the things that can happen with this is people will blame folks who don't do these things. And it's, you know, it's not always possible. You know, if you're first in the line of fire, obviously there's not much you can do. So again, just sort of being aware of that and keeping yourself safe. I mean, that is my biggest thing. If this ever happens, heaven forbid, is that I want to keep you all alive. All right, we're gonna go back to our normal psychology research. All right. Well, and that's the nice thing is he did talk about how like the FBI is researching this and researching how to prevent these types of things, which is great because the FBI does employ a decent number of psychologists to study these types of things. So we talked about experiments in general. So we're going to talk now about some of the extensions of that, just like we talked about the extensions of the correlational method. So probably one of the most commonly used is quasi-experiments. And this would be if there's not a way to randomly assign people. So who can think of a variable where it's just physically impossible to randomly assign someone? Yeah. The number of participants. Well, that could be part of it, yeah, but I'm thinking like, let's say you have the right number of participants, but you want to study a variable that you cannot randomly assign someone to. Yeah. Like gender? Yeah, gender, right? We cannot randomly assign someone to be a specific gender or sex, right? Other things that are unethical. We can't randomly assign someone to experience a traumatic event or to be abused, right? Things along those lines. So instead what you do then is you get what are called matched controls. So you get controls who are the same age, the same general demographics as your sample, and you can then study things that way. Natural experiments are why I have the picture from 9/11 here. These occur when nature itself or a larger man-made phenomenon manipulates the independent variable. So we can think about the horrific earthquake, right, in Turkey and Syria this past week. There will be psychologists who study the aftermath of that, not to exploit it, but to figure out how can we help people who've been through that scenario, right? I'm sure there will also be geologists studying it to figure out how to have better early warning signs. In the wake of September 11th, there was a lot of really good research done, predictors of developing PTSD, effectiveness of therapy. One of my favorites that I thought was like really good, but things you don't normally think of was the higher incidence of alcoholism among Red Cross workers who helped after the attacks, right? So thinking about the people who are carers. I have a friend from grad school who does trauma and public health work. And when the tsunami, earthquake, nuclear disaster happened in Japan, he actually was sent over there to provide like on the ground therapy to the folks who had been a part of that. So, and like a lot of what they did in that scenario, they learned from 9/11, like they learned what works and what is actually more harmful, right? There's a lot of things that are actually more harmful that we want to avoid. Analog experiments are something we would do for more basic behavioral things or early medication testing. And these involve using animals in the lab to examine behaviors. And obviously this is very controversial. Some say the benefits to humans outweigh the costs. Others say they're cruel and unusual or not accurate representations. Certainly our neighbors at PETA in Norfolk would probably be on that side of things. So it's certainly something to consider, and obviously a whole bunch of nuance goes in there as well. So the last type of study we're going to talk about, although certainly there are many other types of studies you can do, is the single subject design. So this is basically combining the experimental method and the case study. So you're doing an experiment, but only on one person. And so these are usually used to develop and test therapy techniques within a scientific framework. So the same individual is studied over a period of time, and behavior at one point in time is compared to behavior at a later time. Usually after some sort of treatment, or what we sometimes call intervention, has been introduced. A common single case experiment is the ABAB design, and the letters just indicate the different phases of the experiment. So the first A is just your baseline. Client comes in, you haven't actually done anything to help them yet. You say to get, how often is this behavior? The first B is when you first introduce your IV, and in this case, your independent variable is going to be your treatment. And then you see, does the subject, does the participant, does the therapy client's behavior change after we introduce that therapeutic technique, that independent variable? If it does change, and hopefully for the better, right? That's great, but that does not necessarily mean that is the cause. There could have been something else going on in this person's life that happened at the same time that caused it. So what you do is you have a second A where you take that IV away, whatever that therapeutic technique is, you stop doing it for a week or two. And then you see, does it go back to baseline or at least get worse than when we were applying the treatment? And if that was the case, then what you do is you reapply the therapeutic technique, and obviously now you're not going to take it away, you're going to use it to help the person to change their behavior. So this is a single case design of a subject whose name was Chris. She was a 19-year-old woman, but she had severe mental delay. So what this means is that sort of developmentally, she was probably more 9-10 years old, somewhere in that range. Since the age of 3, she had a disorder called trichotillomania. Not something y'all need to know the word for, but trichotillomania is hair pulling. And so some people, when they get stressed, anxious, things like that, will just pull out their hair. And it could be the hair on their head, that's probably the most common, but people will do arm hair, leg hair, pubic hair, eyebrow hair. I've had one student in my career who had trichotillomania and was open with me about it. And one time I got an email from her at like 1 in the morning, like, I don't know what I'm gonna do with my life. And so I was like, come in and meet with me at X time. And like half of one of her eyebrows was gone that day. So this is something that unless you get some really good treatment for it, it's really hard to stop doing because sometimes you don't even realize you're doing it. The problem is the therapy that was developed to help people with trichotillomania is very intellectual. It's cognitive behavioral therapy, which is great. It's got research, it supports, it works. But like for someone like Chris, they just weren't going to be able to engage with it in the same way. So her therapist had to come up with something that would help her. Because Chris's trichotillomania was so bad that she would have large bald spots in her hair. And this is, again, not uncommon. So here you see, I think her therapist tried a lot of different things. And none of it was really working consistently. And so then they decided to do this ABAB design to see if maybe a simple treatment approach might work. And so what they did is they found Chris tended to pull her hair the most when she was watching TV. So I believe her parents set up a camera to monitor her hair pulling behavior. And during the baseline phase, they were measuring the percentage of time she spent pulling her hair. So you can see at some points during baseline, she's spending like 80% of her time watching TV pulling her hair. In the treatment phase, again, they were trying to think of something simple that will work, that, you know, again, doesn't require this sort of high level of thinking, but will help, you know, Chris out. And so what they did is they put those 2.5 pound wrist weights on Chris. And what this did was help her realize when she was moving her arm to do it, just made her more aware of her arm movement. So her hair manipulation went down to 0 when they did that, because it was like she could catch herself when she was doing it. Well, you've seen there have been a couple other times where they tried other stuff and it seemed like it was working for a little bit, but it didn't. So again, they were like, all right, so what if we take the weights off? And she resumed manipulating her hair at about the same rate as she'd been manipulating it before. And so the second bead, they put those weights back on and she stopped again. So again, sometimes in therapy, you have to be creative, right? And come up with simple things that might help a lot. And this was one example of that, where it helped her to stop this obviously self-destructive behavior. This is just, again, a little cheesy comment about these things. And one thing that for years I've been meaning to put in my slides and I never have, I'll have to be trying to do this, but I want to touch on is the difference between statistical and clinical significance. Picture. Okay. So statistical significance is typically what we talk about when we're talking about something being significant in psychology. All right, we've done some stats. We found that P is less than 0.05. It tells us there's less than a 5% chance this happened on accident. Basically, statistical, we're trying to get at, did the change occur because of what we did? Because we put the weight on Chris, because we tried some therapy with someone who came in with a different disorder. However, you can have statistical significance without it actually being clinically significant. So clinical significance is, does it actually improve that person's quality of life? I'll give you all an example. And this is, again, a lot of really well-meaning psychologists do this without realizing it. You'll see great large-scale treatment studies, and they'll talk about, we had a 5-point reduction in Beck depression scale scores. Well, okay, let's say the person has a, you know, the average for the sample with a 42 on the Beck depression inventory, and they got it down to a, you know, 37, 38. That's still in the severe depression category, right? So is that actually making a difference to that person's quality of life? Maybe, maybe not, but it's something that we need to think about, particularly as we deal with psychopathology of like, are we actually helping people or are we just moving numbers, right? And we want to avoid just moving numbers and we want to try to actually help people. I know, novel concept, helping people. What? But again, I think very well-meaning psychologists, I'm going to throw this in while I'm thinking about it, just are like, yay, I got significant results. I can publish them. And they don't stop and think like, did I actually help anybody? So. There we go. And clinical. There we go. Then future generations do not have to put up with my atrocious handwriting on the board. Okay. Alrighty, so the next thing we're going to start talking about is the aspects of clinical work. So these are the things that were you to work within a mental health field, you would be doing. And I think some of these surprise people. Because I think a lot of folks think, well, you just treat the person, right? They come in and you use your magic therapy and you help them get better, right? And in fact, that may or may not be the case, depending, but even if it is the case, you actually need to engage in specific things to get you to the point where you can help them. And those things are usually assessment and diagnosis. And so that is a lot more of a psychologist's work than people realize. And this carries over if you are in any of those master's level positions or a psychiatrist or any of these mental health professionals that we've touched on already. So I'm just, because I forgot to do it when I first came in, taking attendance really quickly. Good moves. Okay. These are some abbreviations I didn't learn until I was in graduate school. And so if you're someone who likes to take notes, these might be helpful to you. Or if you're someone who abbreviations actually make things harder for you to remember what you're talking about, ignore this slide. Basically, like BX is used to abbreviate behavior. DX is used for diagnosis. D/O is used for disorder. HX is history. You can use the little psi symbol, which can also be like this, kind of look like a little pitchfork, to be psychology. SX is symptom and TX is treatment. Just to be confusing, some of these are consistent with what medical professionals use. But for example, when medical professionals write SX, sometimes it also means surgery. So just heads up on that if you ever worked in a health psychology setting. Alrighty, so the first thing you do whenever a client comes to you and wants your help is you have to figure out what's going on. Why are they here? How could we help you? Right? And so it sort of is, how is your brain doing? Right? And so assessment is a collection of relevant information. So it's a process of collection, I should say. It's not just like the information randomly shows up. Right? Woo, woo, there's my collection. It's the process of collecting relevant information in an effort to reach a conclusion. And it's geared towards idiographic information. So if you remember, we talked about idiographic versus nomothetic before. Idiographic, which is individual information about the client, that person sitting in front of you, as opposed to the nomothetic information, which is more general information about a disorder. That's like the definitional level. Now, one thing I should say is you will hear me use various different words to describe that person who is partaking in therapy. What I typically use the most was client. That's used to sort of empower the person as part of the process. So like you're a client of an attorney and you assist in your defense, right? If you're a client of a therapist, you're assisting in your own therapy. If you're in any kind of hospital setting, the person will probably be referred to as a patient, which some people hate. And, you know, a lot of times you just adapt to the lingo that's used, right? The other term that I've heard used, but really only in one place, is consumer. And this is supposed to be a very like person first language, that the person is sort of actively seeking out treatment and they are the decider of whether it works for them or not. The problem I have with the term consumer, and this is just me personally, I've never heard anyone else have the same issue, is it just sounds like you're going to Target, right? Like, I'm a consumer. But again, you'll hear these words used like interchangeably. But I typically am going to try to use client because that's what we use most consistently. So what you do in a clinical situation is clinical assessment. And this is the collecting of information to determine how and why a person is behaving the way they are. Usually they don't come in unless A, they're forced by somebody else, or B, like their behavior is disturbing to themselves in some way, right? And obviously that also includes things like mood and thoughts as well as behavior. So you're trying to figure out, is there a disorder essentially? And if there is a disorder, what disorder is it? And then you're also trying to figure out how can you help that person? So what treatments are available that are been shown to work for this type of disorder, right? Or maybe they come in and the type of assessment they want won't even necessarily lead to therapy. So for example, as part of my clinical training, I did, I want to say 2 years, maybe 3 years of neuropsych practicum. So what I did was I assessed people typically for ADHD or learning disabilities, but sometimes also for memory issues, things along those lines. And so those people, the vast majority of time, they were not going to become therapy clients at our clinic. Instead, what they wanted and what we ended up giving them was documentation they could take to our office of, I loved that it was called, that they called it student accessibility services instead of student disability services. And say, hey, I need accommodations. So there are cases like that. While I was on my clinical placement, essentially a practicum in a setting outside of our training clinic, while I was a 4th year, I did a lot of pre-surgical evaluations for people who wanted to undergo bariatric surgery. So these people were going to get gastric bypass, gastric banding, gastric sleeve surgery. And those, some of them we would keep as therapy patients if they needed a little bit of extra support. But the vast majority of folks that came in, we evaluated them. We said psychologically they should be able to handle all the changes they need to make after treatment. And that was it. So sometimes the assessment itself is the only interaction you're going to have with this person. Assessment is also something that could be ongoing throughout treatment. So for example, a lot of modern treatments, you will assess the main symptoms you're looking at the start of each session. And this can be when the person first comes in, either you or like the administrative assistant at your clinic hands them a questionnaire to fill out. 21 questions. You can fill it out pretty quickly while you're waiting for your therapist. You go in, you look at the response together. With some of my clients, we'd even graph it. Where's your depression at right now compared to where it's been? So this tells you whether treatment's working, and if all of a sudden it spikes, you know you want to like really focus on what's going on that week with your person, right? For eating disorders, we would do things like if we're trying to get them to regain weight, we would calculate their BMI every week. And actually, this can, as much as BMIs are a problematic measure in and of itself, I won't go into that. It's a little irrelevant for this class. But like, it can be helpful because most people with eating disorders aren't familiar with it. And so it's more disguised than like their weight, if that makes sense. Like they know their weight and they know where their weight wants to be and they freak out when their weight is higher. But if you show them their BMI, they're like able to process that a little bit more easily. So there's lots of types of assessments that can be really helpful throughout treatment. And again, collaborative process with your client, you often graph them and talk about their progress or lack thereof. Standardization is extremely important in clinical assessment. So this means setting up common steps to be followed whenever an instrument or test is administered. So a good example here, and I will have the full name of this spelled out later, so you don't need to worry about scribbling it down now, but is the Wechsler Adult Intelligence Scale, or WAIS, W-A-I-S. And that's what you see being done here. And so the manual for the WAIS, which is what she has propped up here, it's actually created so you can prop it up as you go, will tell you not only exactly what to say and what steps to take, but it tells you how far from the client you're going to put this book and how you're going to lay out the materials and what you're going to time and what you're not going to time. And the idea with this is if I gave someone a WAIS here in Virginia and one of my old colleagues in Ohio gave someone a WAIS and my friend who works in San Diego gave someone a WAIS, we should all get the same score, right? Because the instructions are standardized. So it's trying to take out any kind of assessor bias. And for something to be used like diagnostically in a clinical setting, it should have really good standardization and really good consistency. And that's actually what we're going to talk about next. Oops. Why not double click? There we go. Is consistency. And so the way we talk about consistency in psychology, because we always got to come up with fancy terms for everything, is reliability. And so there are different types of consistency or reliability that we look at. So let's say, like we talked about last time, you're having observers watch kids with ADHD to observe their behaviors. Well, what you want to look at there is inter-rater reliability. How much do the two observers agree on their ratings of those behaviors? So if the same two people are watching the same text or looking at the same paper and rating it, do they agree? Then there's test-retest reliability, and that refers to the extent to which scores are similar for a person being observed twice or taking the same test twice. And it's typically this. So like I'm developing a new questionnaire of a personality trait. I'm going to make up a personality trait, fluffiness. I don't know. She's like happy shininess. Right? If I give this to you now and I give it to you in 2 weeks, your score should be pretty similar if I'm assuming this is a stable personality trait, right? So that's test-retest reliability. That the same person takes it now and takes it later, and their score should be very similar. Now, there are some tests you don't want to have good test-retest reliability, right? If you are measuring something that you hope to change during therapy, like depression or anxiety, you don't want that to stay the same, right? So this is not something we look for in every measure that we give. One thing we do typically look for, though, is what's called internal consistency. And this examines whether all the items on a test are related, right? So let's say I made up this test of like happy shininess, and I'm like, I enjoy everything. I like this scenario. I like this scenario. And then it was like, I hate the world and everyone in it. Well, that could be a reverse coded item, or it could be something that's not going to give me good test-retest or internal consistency. Better example that I often use is like, let's say you're measuring depression and you're like, I've been feeling sad, I lost my appetite, I've been sleeping a lot, I like to play frisbee, right? Just something really random. You're gonna have really bad internal consistency if you keep that item in there. And this is super dated now, but these are the original American Idol judges. And I use them as a really bad example of inter-rater reliability because they would often not agree on anything. Like Randy would always be like, yo dog, it was a little pitchy dog, I don't know. And Simon would be like, that was horrible. And then Paula would be like, you are so beautiful, and that was great. It's a really bad inter-rater reliability, which makes for good TV, but if we were looking at something psychologically, it would be bad. So validity is the accuracy with which we're measuring what we actually want to measure. So reliability is consistency, validity is accuracy. So this assesses the extent to which a test or instrument fulfills its intended purpose. Is it actually measuring what it's supposed to measure? There are different types of validity, and again, we don't always want them. So face validity is, does it look like it's measuring what it's supposed to measure? So if I, again, gave you a depression inventory and I'm asking you about feeling sad and sleepy and things like that, that's pretty face valid. Not all of our clinical assessments will be face valid, and that's okay. There are reasons for that, because sometimes we're trying to get at like underlying things. Predictive validity is, can it predict what will happen in the future? So things like treatment outcome. If this person will be violent to themselves or other people, things along those lines. Concurrent validity is the degree to which if we take two measures of depression and give them to the person on the same day, those scores will be related. So it's basically saying, yes, these are both measuring depression. And in fact, when you develop a new scale, this is the most common way to try to validate it, is to compare it to existing sort of gold standard measures. The difference between predictive and concurrent validity is that predictive looks at 2 different time points, whereas concurrent, it would be at the same time. I mean, you can kind of get that just from the word concurrent, I guess, but I think sometimes it's helpful to clarify. Content validity refers to whether a measure adequately samples everything that could be part of what you're trying to measure. So if I was measuring depression and I only talked about being sad, and I didn't talk about like lack of interest in activities you usually enjoy, or physiological changes, or thoughts of suicide, then I'm missing a big part of what we know makes up depression. So content validity is making sure I'm including everything that's part of what I'm trying to measure. Construct validity refers to whether a measure of a construct is supported by those other measures. So essentially, construct validity can be measured with the concurrent or the predictive validity. And so is this measuring what it's supposed to be measuring? All right, so the very most common way to start an assessment, and in fact, just about any assessment you ever do is going to include at least some version of this, is a clinical interview. And this is where you sit down and you talk with the person about what's going on with them. And you gather information about their lives and their circumstances. There are 2 types of clinical interviews. Unstructured interviews typically consist of open-ended questions that you can follow up on as needed. Tell me what brought you in today, was how I would start pretty much every interview with a client, because I want to hear in their words what's going on with them. Tell me about your previous psychiatric history, your previous medical history. So unstructured interviews are a way of gathering a lot of information about clients, but also you can use them to observe any nonverbal behaviors that might be really helpful in determining what's going on with them. So for example, does the client avoid every question you ask about their substance abuse history? If they do, this could tell the therapist there might be something more going on there, right? Circle back to that and come back to that when the client's feeling more comfortable talking to you. Other things, people who are depressed, and I have a hard time doing this because I naturally talk so fast, so give me a second. But they talk in a monotone like this, very slowly, and it can be like hard for them to get words out because there's a lot of effort involved with that. People who are anxious, right? They'd be like fidgeting with their fingers or their watch, or like their leg is bouncing up and down the whole time you're talking to them. Things along those lines. Other behavioral indicators. Could they find your office? Did they show up on time? If they didn't show up on time, did they give any explanation? Do they look like they are grooming themselves? Right? And again, this isn't judgmental, it's just more information about a client and what's going on. So I've had very severely depressed clients. I think of one in particular who told me she could only bring herself to shower once a week. And it was before she came to our therapy session, because that was one of the few times she left the house. You know, or if you see exchange, this can also be important throughout therapy, right? So let's say your client usually comes in very polished, and one day they come in completely in disarray, and it's at the same time. So it's not like they didn't just come from work like usual, right? Those are things that can tell you something else is going on here. Structured interviews are more aimed specifically at diagnosis. So here the therapist is going to ask the client specifically about the symptoms they are experiencing. The format of the questions is very highly standardized, and the person's answers to the questions are scored according to concrete criteria. It's often like a yes, no, things along those lines. So the structured clinical interview, and I was trained on the one for the DSM-4. There obviously one exists now for the Diagnostic and Statistical Manual 5th edition. This is a general overview of the most common disorders. And so the very first question you ask every single client is from the depression section and you say, over the past 2 months, has there been a period of time where you've been feeling depressed or down nearly every day? Most of the day, nearly every day. I used to have that memorized better. So I, again, would ask every client. And then there are some prompts where you can probe, but in a very like I used to warn clients when we started the skit, because we would do the unstructured interview first, and then I'd be like, okay, now we're gonna move into the standardized interview, and I'm gonna sound completely different, because I have to ask these questions in a very specific way. So just roll with me, because it'll help me gather information that will help me help you. You have to be a lot more standardized. And there are structured interviews that go for specific disorders as well. So for example, when I was working at the VA, I was trained in the interview specifically for PTSD. And there's one that exists specifically for eating disorders, and one that exists specifically for schizophrenia and other psychotic disorders. You might either informally or formally do what's called a mental status exam. If this person is coming through to you for anything like memory issues, attention issues, things along those lines, you would probably do a formal mental status exam where you ask a set of questions and observations that systematically evaluate awareness of where they are, right? Orientation, which includes things like who are they, what time is it, what's the situation, why are they here, attention span, memory, thought content, things along those lines. So what is today's date? What city and state are we in? What building are we in and what floor? Why are you here today? And you might give, like one of the standard ones we gave had like, you would give them 3 words, ask them some more questions, and then ask them to like tell you back those 3 words, things along those lines. If the person is coming to you for, I don't want to say like a typical clinical issue, because that sounds weird, but for something like depression, anxiety, things along those lines, you might not go through a formal mental status exam. Instead, you're going to use those nonverbal cues. Again, things like their appearance, how disheveled they are, their thought content, their mood. Are they able to find your office and get themselves there sort of close to on time? Things along those lines. And obviously, even if they come in from one of those types of disorders, and if it becomes clear to you they might not have the best mental status, you can easily switch into a formal mental status thing. Because one of the things I learned during my years doing those neuropsychological assessments is that the symptoms of depression and anxiety in particular can manifest in ways that look like ADHD or a learning disability. So for example, the folks I tested who had anxiety, specifically like performance anxiety on exams, they would have the same problems people with ADHD have when they took an exam in sort of a normal classroom situation without a quiet environment to take it in. So we were able to get them accommodations just as if they had like a diagnosis of ADHD. There are several limitations to clinical interviews. So, if you're really trying to do something formalized, you wouldn't stop with just this. They may lack validity because sometimes people don't want to report accurately. I don't know you, you're some stranger, you're asking me all about my life, right? Or sometimes they can't. Sometimes they don't even realize what's going on and how much of a problem it is. Things like, well, yeah, I don't know. Sometimes I don't eat all day, but that's normal, right? Well, how often does that happen? I don't know, like 4 or 5 days a week. Maybe not so normal. So you have to kind of know how to probe to get at some of those things. Second, interviewer bias may unfairly influence how clinicians interpret results. Give you an example. When I was on my placement year, there was a very well-meaning psychiatrist across the hall who did not believe that unipolar depression existed. So he didn't think a major depression disorder was a thing. He thought anyone who came in his office who had depression was bipolar, they just hadn't had their manic episode yet. This is not a thing. Depression exists. It's the most commonly diagnosed mental disorder. So, whenever I got a referral from him, I had to like really kind of reassess the person and see, is it actually bipolar or is it just depression? Sometimes it comes in like less harmful ways. So for example, we asked just sort of like a standardized question about people's eating habits because things like anxiety and depression can interfere due to stress with your eating pattern. But as someone trained in treating eating disorders, I would pick up on things that other people might not, like people who were using eating as their only way of coping with stress. And so target that as something to address in therapy as we addressed everything else. They can also lack reliability as people respond differently to different interviewers. And sometimes people would come into the clinic and purposely request specific kind of interviewers for that reason. So for example, we had a male client once come in and we were in our training clinic, we were all considered in the same bubble of confidentiality. So we could talk about our cases so that we could learn from each other. And obviously we didn't talk about them outside of other students. So it's just sort of like allowed us to process things and whatnot. And so this guy really was like adamant, I need a male therapist. And I happened to be there with another clinician when he got done and we were like, what was going on? And he said the guy had an impulse control disorder where he was masturbating 6 hours a day. And like you can understand why he might not want to talk to a 20-something female about that issue, right? Fair, right? A lot of folks of color are really seeking out therapists of color now, particularly because those therapists are much more likely to understand things like generational trauma, right? Things along those lines. The problem with that is there's unfortunately not a lot of diversity in psychology. So I'm like hoping you all go forward and help with that increasing diversity. So, we really need to be adamant about opening up our doors more. I think there was COVID strangely, like, we have to look for the silver lining sometimes, as hard as it is. But, like over 1 million people having died in the US of COVID alone. But like during COVID, a lot of people started realizing I need mental health help, right? B, I can do this remotely, so that opens more doors. And then C, universities were like, oh, no one can go to a testing site and take the GRE. So I guess we're going to waive the GRE requirement this year. And not surprisingly, applicants went up quite a bit. And in fact, they saw more diverse applicants, more first gen, more people of low socioeconomic status, more people of color, the folks who are often stopped by those barriers. And again, I don't think these barriers are meant to gatekeep, but they end up being gatekeeping. Where, the GRE costs what? Has anyone taken it lately? I think it's like $400 to take or something.
Yeah, I recently signed up for it. It's like $200.
Okay, it's not as bad as I thought, but still, that's a lot of money, right? For a lot of people, that's more than a week's paycheck, right? And you're trying to eat and buy your books and things like that, right? So yeah, it's we need to think as a field about how do we bring people in who have had barriers up to better serve the people that we need. And honestly, just in psychology in general, we need more therapists. There are waiting lists for therapists all over the place, right? Because again, a lot of people during COVID realized like, I need mental health help. And it was really hard to get in with somebody. Alrighty, we're gonna start talking about projective tests. These are the ones that people typically find the most fun to look at and engage with. So these are things like the Rorschach ink blot tests. These are the things that are portrayed in movies the most, I would say, when you see a psychological assessment. I guess they're more engaging and exciting than like watching someone just talk to somebody. Fair. And so projectives give patients or clients vague stimuli. They could be ink blots, they could be pictures, they could be words. And ask the clients to give their interpretation of that stimulus or follow open-ended directions. So like one of the projectives for kids is like the draw a person test. And you say, hey, draw a person. And then you kind of see what comes out of it. And these, the idea behind these is that because they are so vague, clients will project their personality, their psychopathology onto these vague stimuli. These are primarily used by psychodynamic clinicians to assess unconscious drives and conflicts, but they're still used quite a bit by clinicians of other orientations. And I don't mean, sorry, sexual orientations, like theoretical orientations, realize I could clarify that. For example, we all in my graduate program asked to learn the Rorschach because for some reason, if you apply to APA accredited internship sites in the Northeast, like New England, they want you to know how to give the Rorschach. I don't know why, but they still use it a lot. So we learned how to do it. I've given a grand total of 2 in my life. Wasn't my favorite, mostly because it takes you forever. Giving it doesn't take that long. Giving it is about a 20 to 30 minute process. But scoring it would take me, scoring and interpreting would take me about 6 hours each time. Now, granted, that was also because I was new, right? I'm sure if I kept doing them, I would have gotten that down quite a bit. But yeah, wasn't my favorite for that reason. And so this is Dr. Rorschach having gotten run over by a bulldozer, and they're trying to interpret his blot. Alrighty, so this is the Rorschach. I've heard it say both ways. And it's a series of ink blots, like this one. And the individuals are asked, what might this be? And that's really the only prompt you start with. There are a couple ways you can refine it. So, for example, if on the first blot, they only give you one answer, you can tell them lots of people see lots of different things. So, you know, what else might this be? Because there are 10 blocks, but in order to get a scoreable response set, you need 14 responses at the minimum. And I don't really know why, but that's what they decided. So, it was developed from a parlor game called Blotto, where this was back when they had like inkwells and like either fountain pens or things like that. And so they drip ink, close it, open it up, and it would be like little kids laying on their backs watching clouds go by. Oh, I see a bunny, things like that. And then Herman Rorschach said, what if we could use this in a clinical book? And so a couple things here. One is that this is the type of blot I'm supposed to show you because this is a not actual clinical blot, it's just a representation. This is blot 1 from the Rorschach test. And that is my former cat, my cat I had in grad school. And it was funny because I brought them home because I was going to take them to my placement site to give the Rorschach there. And I just sort of put it out and I thought, oh, she'll ignore it. She stared at it for a while. I was like, what are you seeing? What might this be? But you know, she was a cat, so she couldn't tell me. But you know, technically, I'm not supposed to tell y'all or show y'all the real blots. And I'm just gonna show you why I don't care about showing you one of them. Because if you go to Wikipedia and you scroll on down, here are all 10 ink blots. I still don't know how they are getting away with this. This has been up for like 15 years now. It cost me $75 to, I mean, it cost the school $75 when I got here to get a set of ink blots I could use in my assessment course. But you could just get them for free. The other really problematic thing about them being on Wikipedia is it gives you like common answers and interpretations. So technically, and it's not really used this way as much anymore because some of the validity has been called into question. But technically, if someone was giving you this in like a legal setting, you could use Wikipedia to like cheat, basically, and give like non-crazy answers or crazy answers, depending on if you're trying to get like not guilty by reason of insanity. So again, that's why I don't mind showing you part 1 because they're all out there now. I even have, I didn't even think of it. I should have worn it today. I even have a dress that has some of the Rorschach blots on it now. So, you know, public domain, even though you actually have to pay for the real cards, I don't know. But yeah, so that's the Rorschach. This is like the most commonly shown one in movies. I remember there was some movie, I don't even remember what movie it is, but like they're showing the ink blots and there's someone observing the assessment. And he's like, oh, I see a fluffy bunny. I see this, I see that. And the person who's observing is like, that's not what he sees. And like kind of sets up and they kick him out. And then the assessor is like, what might this be? And he's like, blah, and then he attacks the person. It's a little silly, but it might be. I'll have to look into it. I found the clip at some point a few years back, and then I only put it in like one PowerPoint and I forget which one. So every time I'm like, I need to find that again. I will look. Thank you. That's a great idea. All right, there are other types of projective assessments. One of these is the thematic apperception task, or the TAT. And this involves being shown any subset of 30 cards. This one really, like, I never administered this one, but it's like, you kind of just get to choose which ones you show. Like our assessment supervisor, Jack Graham, who unfortunately just passed away in December. He had like his own set of TAT cards he liked us to use if we gave it, but very unscientific. Like my manuals for things like the waist and whatnot are pretty thick. The manual for the TAT is like a little booklet, 20 pages. So it is a little free form. If you show them these pictures and you have them make up a story about what might be going on in the picture. And so who they identify with, the emotions they express, and particularly recurrent themes are how you interpret it. And so, for example, let's use this one. What might be going on here? And like I said, I've never given a TAT, so I can't actually assess you based on it. So shout out whatever you think it might be. Yeah.
They got into a fight and
Yeah, so they've been fighting. He just went to sleep and she's upset. Yeah, what else? Yeah.
he could be sick.
Yeah, maybe he's sick and so she's worried about him. Did you have something?
I don't want to say dead, but
No, that's a common one. So it's tough to shoot. Yeah, a lot of people will be like, he's dead. Another common one people say is like she cheated on him or he cheated on her and she just found out, right? And so none of them are right or wrong. They're all just sort of interpretations of what's going on. And again, you look for those themes. So if like every single card, the person's like, that person cheated on that person. They're like, okay, what's going on in your life right now, right? But to give you another example, when I took intro psych, the equivalent of our psych 102 when I was in college, it was with a clinical psychologist and he had given the TAT. He told us a story about there's one that just like shows a picture of a lake and I think there might be a bench in front of it. And when he asked someone, you know, what might be going on in this, tell me a story about this, they said, oh, well, you know, a couple just left, they've been sitting on that bench watching the person drown that they murdered. And I was like, and that was basically, I mean, when you're in a clinical setting, you got to keep your face straight, right? But like in his head, he was like, that blinking guy mean, right? The most commonly used one in this day and age is sentence completion. At least in my training experience, I gave a lot more of these than Rorschach's. And there's a couple reasons for that. One is that it's self-administered. So if I'm giving like a TAT or a Rorschach, I need to be sitting with the client while they do it. If I give them sentence completion, I give them essentially a questionnaire and they can do it on their own while I, you know, score something else or I don't know, have lunch or something along those lines. It's also pretty quick to give and it's a really good insight from it. So they are just starts of sentences. They call them stems. And so they're supposed to be ambiguous, again, on purpose. So things like I wish, or it's, you know, based on psychodynamic theory, so we've got to have a my mother in there, right? And again, you look for themes. And again, here's an example of interviewer bias. We had a really good, like, supportive network within our training clinic. So I once did a neuropsych evaluation on someone one of my friends was seeing as a client. So she was seeing this client for depression. The client had been through electroconvulsive therapy, ECT, which we'll talk about more when we talk about treatments for depression. And the client had been, one of the things that can happen as a result of it, it's rare, but it can happen, is memory loss because you're applying electrical current to the brain. So she was actually worried about this. And so I tested this person when there was like assessments. She did actually have some memory issues, which was sad, but we were able to give her techniques to use to help her get around those. And I gave her one of these, and over and over and over, she was mentioning food. And again, not something necessarily someone who wasn't an eating disorder therapist would pick up on, but it's something I certainly mentioned to my friend who was giving her therapy. And she told me a couple months later, yeah, we talked about that, and that was a big issue for her. So thank you for bringing that up. You know, it's not something she'd ever brought up before. So you can get some good information from this, even though, again, it's fairly short. All right, so the next thing we're going to start talking about, and we certainly won't get through this whole discussion today, but we can dive in, is personality inventories. So these are called personality inventories, but I think they could largely be called clinical inventories. What they are very long multiple choice tests, ranging from like 300 to 500 plus questions, but you're typically answering them true, false, or on a 4-point Likert scale. So it goes a lot faster than you think. So for example, when I was giving one of the most common ones in grad school, the MMPI, at that point it was 567 items. It's been whittled down. And the average college student could complete it in about 45 minutes because it was just true, false. True, false. This is true of me, this is false of me. But because they're so long, you get a lot of information from them. So here's something you can give to someone that takes about 45 minutes to an hour, and you get a lot of really good comprehensive information about what's going on with them. And in my training clinic, we gave one of these to every single person because we had a very large MMPI research program going on. But it meant that we got really good at interpreting them and writing about them, and good at figuring out what they meant in terms of like treatment for our clients. So these are focused on behaviors, personality characteristics, beliefs, feelings, and they're usually based on self-reported responses. Again, the person just sits there and fills it out by themselves. It is important to note that only standardized psychological personality tests should be used in clinical practice. Something like this, where they're taking one of those online quizzes. I mean, this day and age, it's like BuzzFeed quizzes, right? When I was in college, there was a site called like Tickle that was basically like BuzzFeed quizzes before BuzzFeed existed. When I was in grad school, for some reason, there were these quizzes on Facebook. My favorite one I ever took was, "Are you a hamster?" But it was spelled wrong. I was not a hamster, shockingly to everyone in this room, I know. So you don't want to be using these. Those are fun to fill out, right? Things along those lines. But there's also ones that present themselves as scientific that you also shouldn't be using because they're not actually scientific. The Myers-Briggs is an example of this. It doesn't have a research foundation. It was developed by 2 non-psychologists. And the Enneagram or Engram, however you say it, is along those lines. Again, they're fun. They can be really fun to fill out, just like a BuzzFeed quiz, but like we shouldn't be making clinical decisions based on them. And in fact, like the waste, like the other things we've talked about, you have to have a really high standard of reliability and validity to use these tests to help you make clinical decisions, right? So typically, tests you use in an applied clinical setting, you want reliabilities in the range of 0.9 and above. 100 would be perfect. 0.9 is excellent. For research, 0.7 level is okay, right? So these are the best of the best so that you're making sure you get accurate information. All right, so I just mentioned the MMPI. I'm never going to make you guys spit out what the full title is, the Minnesota Multi-Phasetic Personality Inventory. MMPI is fine. As I mentioned, the original version and the 2 that I was giving when I was in grad school consists of 567 items. And you just respond true, false. You say, is this true of me, is this false of me? And if they leave it blank, it's interpreted as a cannot say. They didn't know if it applied to them or not. That's an interesting sort of holdover from the very first way the MMPI was devised, was actually as like a card sorting task. So there would be the statements on cards and patients would put them in piles of like, this is true of me, this is false of me. And there would be a cannot say pile. So there's not actually like a cannot say answer now. It's just if they leave the question. Some examples of MMPI items are, I would rather win than lose in a game. I'm never happier than when alone. My hardest battles are with myself. For a long time, I think they finally got rid of it, but for a long time, the first item on the MMPI was always, I enjoy reading mechanics magazines. So they were pretty random. This is one of those tests that like, at least initially face validity wasn't a thing. They didn't really care if the questions looked like they were measuring what they wanted to measure, as long as they gave you the results that you needed. So it has clinical scales and validity scales and a whole bunch of supplementary scales too. So the clinical scales assess symptoms of disorders like depression, but also personality traits such as introversion. And then validity scores here assess how carefully they are taking the test. So there are things that measure, are they just going through and responding true to every answer? There are questions embedded within it at different points that ask the same thing, basically, and are they responding the same way to those? Are there too many cannot says? Did they leave too many blank? If that's the case, as Martin Selbaum, the huge MMPI researcher now, he was a postdoc when he taught me this, said you just fold it into a paper airplane and you throw it in the trash. You can't do much. You would have to like shred it, right? But you know, there are certain things you just don't assess. There are also scales that assess whether you're misrepresenting yourself. And you can do that in different directions. So there's a fake bad scale where the person is like exaggerating their problems. Often that's a cry for help. Unless it's in a certain scenario, like let's say you're trying to get like a not guilty by reason of insanity diagnosis or compensation for a mental health issue. You have to watch those. There's also a fake good scale or the L or lie scale. And this is one that we have to watch when we are doing, gosh, I'm blanking, child custody events. Because the child custody, the people involved in the child custody dispute are actually wanting custody, they're going to try to make themselves look better than they are, right? So the MMPI actually has specific criteria you use for the L scale to interpret it based on child custody evals. So obviously, recognition. Oh, one of the things I should say is I believe your book still says that scores of 70 or higher are interpreted. I was taught 65, so we're gonna roll with 65. One of the fun things about psychology you don't realize until you get into the nitty-gritty is there are politics, just like any other field. And I was trained in the Graham method because Graham was my supervisor. And then when I was on my internship, we had Green come in and do an MMPI workshop, and he's the 70 or above guy. And we were having a lunch, and I think I was sitting like 1 or 2 seats away from him, and I just mentioned casually at the beginning, like, oh yeah, I trained with Jack Graham, and he literally like turned his back on me and didn't talk for me the rest of the lunch. So I was like, oh, it's like that, huh? Okay. Psychologists are weird, y'all, just like anybody else, I guess. But sometimes it's you get people in psychology who want to study what they have, and that can be make for an interesting set of colleagues. We are strangely normal for a psychology faculty here at Wesleyan. So count yourself up. Alrighty, have a great weekend, and I will see y'all on Tuesday.